lady suffering from infertility. She had a successful IVF 13 years ago with a live birth, and she returned to me for chronic pelvic pain, resistant pain, dyspareunia, and no other sign of deep endometriosis. The ultrasound assessment showed adenomyosis, fibroids, rectal involvement with a nodule of less than 1 centimeter, and a bilateral endometriotic cyst. So it was decided to perform total laparoscopic hysterectomy, bilateral salpingo-oophorectomy, and to deal with the nodule according to the surgical findings, but a priori no rectal surgery was decided because of no symptoms from the rectum. The first step for this surgery is to detach the sigmoid adhesion and to release as high as possible the sigmoid and the colon to have an ease to perform the rest of the surgery, and in case of a rectal necessity of doing any surgery, it is easy to do it in this condition. After this detachment, we have access to the psoas muscles and particularly to the IP ligament that show us the way to find the ureter, which is the most important first landmark to search for. This landmark is our guide for the rest of the surgery. Once it is recognized, the ureter is dissected as far as possible, and this dissection will give us some security and some ease to perform all the rest of the surgery, because it's our guide for all we need to do. It's our guide for deep vessels, our guide for avoiding any injury. Trying to detach the cyst from its pelvic adhesion to the rectum and to the broad ligament. We had an opening of the cyst, which is something usual, and give us some more space to work. The second step of the surgery is to do the opening of the pararectal space, medial pararectal space. This second important step gives us the safety for the upcoming dissection to do. Once opened, the gauze is inserted, and we have decided to do at first the left adnexectomy to gain more space and more visibility to this part of the surgery. Here we can see that the ureter is completely detached from all possible adhesion. So we can do the adnexectomy safely. IP ligament is well isolated. Cauterization should be performed at least for 2 centimeters with bipolar. Here we are completely safe because the ureter is under vision. Adnexectomy is completed. Now the right side of our dissection is started. The appendix is with no disease. Here again, the first step is to recognize and dissect the ureter, our guide for all the surgery. Small opening of the peritoneum surrounding the ureter and the IP. Careful dissection. Ureter is recognized and lateralized by gentle dissection, preserving its vascularization. Here again, the next step is the opening of the right parectal space. And dissect the rectum as far as possible. Now it's time to cut the uterosacral ligament, posterior parametrium. That will give us more space to dissect the rectum, and at this time we can recognize the hypogastric artery, its first branches, and also to search for the hypogastric nerve that is very important to preserve for bladder and erectile function. Here we can see the hypogastric nerve that has been preserved. Now all the structures and are recognized. Dissection of isolated big vessels, ureters, and the central lesion is now well isolated. Ureter is completely detached from adhesion to the posterior parametrium, which is, as you see, deeply involved in the endometriosis process, and this posterior parametrium is completely resected. Now we can complete the dissection of the pararectal space. This hypogastric fascia containing the nerve is preserved. And now the most difficult step is to be done at certain point. You have nothing to do but only to cut in the right plane. Here we use scissors and very little bites of bipolar cautery. By using scissors, if we have some injury to the rectum, we can see it very easily. Here, the dissection reached the vaginal wall. Little fibroid. Very low location. Rectovaginal dissection is continued, and after hysterectomy was done with the classical manner.